Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back to the Functional Code. This is episode 8, the body series. Today we're going over the shoulder girdle. I'm Dr. Jace.
I'm Dr. Addy. Welcome to the Functional Code. Thank you guys so much for continuing to watch our series. This is Shoulder Girdle of the Body series. Doc, we're super excited to bring some awesome content for the shoulder. I think people don't realize just how complex of a joint this is and how tricky it can be to manage, especially with the conditions of anything from arthritis to injuries. There's a lot of things that I think people need to do better at when managing their own shoulder issues. So today we're going to jump in. We're going to talk how have humans evolved over the years to go from walking on all fours to actually having 2 legs and 2 very mobile arms that do a lot of things. We're going to talk common conditions that we see in the clinic, how those are usually managed, what we do to get patients back to 100%. Again, you're going to hear it without surgery and drugs because we are dang good at what we do. And lastly, we're going to just talk briefly on tools that you can do to completely bulletproof those shoulders of yours, and obviously the scapula that comes in with it. So, Doc, let's do the shoulder, huh?
Woo! Yes,
so
absolutely.
Today, we're gonna, just like we always do, and kind of how we've brought about the beginning of each of these body series, we're gonna talk just how shoulders came to be. So, Doc, when we were roaming the earth many, many millions of years ago, we didn't quite have the same body structure we do now. So.
Yes.
What happened and what changed moving forward?
I dove into this quite a bit over the last few days. I know we talk about it, I feel like every episode, but to bring more context to this, I think is really important. So obviously most people feel like we've evolved and adapted from apes, monkeys, chimpanzees. So when you look at the bone structures of those just animals compared to humans just even today, there's a lot of similarities, but if you can have a good idea in terms of other structures of like monkeys, apes, that's where when you look back on the bone structure and fossils of the humans, a lot of the bones look very similar to apes, chimpanzees, monkeys. So the first remnants of our early ancestors was known as the Sahelanthropus. I may have mispronounced that, my apologies, but that was found in West Central Africa, actually in 2001. It was a skull of a bunch of pieces put together, and the one distinction they found with that is the foramina magna, where the spinal cord goes out of the skull and downwards, was more in the middle portion and less on the back portion, which pretty much told us that that individual, that being stood upright for a period of time, whether that was them hanging in trees, whether that was scavenging the earth. It's very hard for us to say, but that was supposedly dated 7 to 8 million years ago, and it was projected to have shoulders much like apes, to where they're way more mobile but less stable. Now as time goes on, there's another fossil we found dating back 4 million years ago, and this one was known as Lucy. It was a bunch of bones of the whole structure of this Australopithecus.
Yeah, you got it.
Something like that. Again, I'm probably mispronounced that. And both of those two from the skull size, which was much smaller, much of the size of like a chimpanzee or monkey. This Lucy, this was also a much shorter structure. We're estimating anywhere from like 3 meters high, so very small individual. But around that time, 2 million years ago, we found tools and remnants of stones, of arrows, these sharp objects around these fossils. So we assume that's when, and roughly speaking, when we started to learn how to throw, hunt, use these objects to hunt prey for food to have us survive. So going back to the shoulder girdle, when we adapted, and it's still estimated that, did we even roam on all fours? I think there could be something to that, whether it's walking around kind of like what an ape would do, or we are just hanging in trees. Regardless, we know a few things for sure. The arms got much shorter, the shoulder girdle stabilized, and I think, and this is more theorizing than anything else, I think the back portion of the shoulder started to adapt just to support weight, to stabilize it a little bit more. Thus, I think the chromium adapted, the clavicle, the AC joint more or less adapted just to stabilize it. But I think we're at a point right now with society that we're quickly evolving and that our structures can't keep up with us, especially from desk jobs to specialize on certain sports.
Yes.
We're in this weird time frame to where we add a few thousand years to this. The structure of a human could change very rapidly,
yes,
possibly for the worst.
Or have you ever seen that picture of like what a 20-year-old gamer could look like when they're 60?
No, I would just assume.
I mean, it's, you know, the biggest, exactly, that's that's exactly what it is. They have that awful hump, arthritis in the hands at age like 30. You have just that flexor dominant status where everything, like Doc was saying, is what he's mentioning was when we're evolving quickly. The shoulder is evolving because we have so much roundedness because we're so flexor dominant. And I can't remember what other things, but I just thought that picture was funny because we've almost seen it today. Like we've seen these patients that have come in, and they're so rounded and they're flexor dominant, and I'm just like, oh, give them even 5 more years, and they're not even 30 yet, and they're gonna look awful. But no, I think that was interesting because I was watching a documentary the other day, and they had shown this ape use a rock to crack open a nut.
Yep.
And they said that was actually their species evolving to the Stone Age. They're taking that, basically their free moving shoulder and arm, and to use an object to open, that's legit the Stone Age. So it's just crazy for me to think that the way we have evolved, and it'd be fun to be a fly on the wall during those times to see kind of in a short to a long period of time what changed and how did it change as far as what we looked and how we actually consumed food, hunted food. I don't know. It seems really interesting.
And it's even weird too. Like, I got goosebumps. Imagine if there was like a second human species evolving right in front of us.
Right.
Obviously, we're probably not going to be here long enough to watch it go through, but man.
Yeah, no, that stuff always interests me. All right, Doc. So do you want to jump into the shoulder girdle itself and how it connects from the scapula to the glenohumeral joint itself?
Absolutely. So when you look at the shoulder girdle, this is anywhere from the clavicle to the actual shoulder joint to the scapula. Now all this works together in unison, but the whole shoulder girdle is held up by the sternocleidomastoid joint, is the joint right on front below your chin on the sternum. That's also where your collarbone attaches to. So this joint houses a large portion in stress, thus going back to positions that we find ourselves in rounded. It's going to force many more problems throughout the whole shoulder. So making sure that, one, it's stabilized, but two, that we're able to get motion and movement in many directions throughout moving the arm. And as you go through, there's also tissues underneath the clavicle, one of which known as subclavius. And now that muscle, it runs horizontally. It doesn't have too much muscular action. It's more of a tuner, which helps regulate the tension on the front anterior portion of the capsule. I think of it as a communication between the nervous system and muscles, and it's that fine bridge in between those two, to where as you move your arm in front of you, it puts a limited barrier with any throwing movements, also with the Golgi tendon organs, muscle spindles as well. And those are aspects of muscles and tissues that regulate the communication up to the brain to limit movement. So as we go from the joint to the collarbone to the joint capsule, the glenohumeral joint capsule, that's where it's pretty much a ball and socket joint. However, it can't necessarily move throughout a 360-degree motion. There is restrictions, especially going backwards, coming closer to our spine, and then obviously we can't move our arm into our body, so there's limitations in front of our body and behind our body. But we want to make sure to move freely without pain-free range of motion, but we should be able to move across our body. We should be able to reach behind ourselves. We should be able to reach up overhead, and that has a communication between the shoulder blade, the glenohumeral joint, and also the AC joint. Now, AC joint is on the front. That helps withstand pressure and load against gravity. It also helps for shock absorption. So like if we are going to catch a pass with a ball in basketball, or if we're able to do a push-up or fall on the ground, it's that little shock absorption which doesn't put excessive pressure and load into the ligaments and tendons, not only on the top portion, on the front, back, sides, what have you with that. And then also on the back side, there's a scapulothoracic joint, but it's pretty much a joint between the shoulder blade and the rib cage or thoracic spine. Now that is, it's not necessarily a synovial joint, but it's a joint that we look at between two structures being able to having to move fluently, thus having a communication with the ball and socket joint or glenohumeral joint.
I don't think what a lot of people realize too is, Doc, just how crucial that scapulothoracic joint rhythm is to helping with shoulder stability. And a lot of people, they're like, oh, it's my shoulder. They don't realize that there are plenty of times where it's the scapula and its rhythm change or joint change that is causing the issue of the shoulder. And I think that's something that I don't think people really realize, that it's actually a joint. It's something that needs to be maintained.
Yes, and we're going to get into that too with shoulder dyskinesis. We're going to go into that condition and how you can best stabilize that later on in the podcast, but much the same with Dr. Addy said, that joint has way more influence to the whole shoulder girdle than many people may realize.
Or the shoulder, it's the most mobile joint in the body. I didn't realize that until I looked that up the other day, actually. So, which makes sense given just how much you can move your arms in each direction compared to other parts of the body.
Absolutely. And I think other people would argue, well, why is the hip not the most mobile joint? Well, if you look at the hip, most people can't move their leg backwards or off to the side. However, we can do that with our arms.
Even though it's a ball and socket, still not as mobile as the shoulder. And makes sense. After I injured my shoulder, man, I tell you what, I did not realize just how much influence it had on just normal day-to-day function, having a fully operating shoulder. I almost wish I didn't injure my shoulders, and I wish I would have put it somewhere else, just because of, you take for granted. It's crazy just how much it affects just normal motion, even walking. All these things, it's crazy. So,
and I think most viewers would like to hear an update on how is the rehab been going. Is there any updates? If you feel free.
Absolutely. So for those who are just watching, when I injured my shoulder, I had a couple fractures. I had a torn ligament. I had a torn muscle. And for the kind of outcome that I was expecting, it was going to take probably anywhere from 3 to 6 months, just because of how drastic of an injury it was. And when I was speaking to my surgeon, he had mentioned that it was a very lucky injury, so I was very grateful to hear that. He had mentioned it's going to maybe take a couple weeks to a month to figure out if surgery is needed. So the last check-in was 3 weeks ago, and he had said so far he doesn't think surgery is going to be needed, so that was a huge, awesome update. This upcoming Tuesday, which will be in a few days, is my next check-in with him. And that's going to be when we get the final call if surgery is not going to be needed or not. And for me, as far as progression goes, I'm now able to, I would say 90% of my motion has been restored.
Wow.
As far as being able to do things, I really am not limited other than lifting really heavy weight, but I am able to do push-ups, and I'm getting to that point where it should only maybe hopefully be another month or two before I'm back to 100%. But doc's already seen, I've been adjusting patients here and there as best as I can, and super grateful to have the team that I do here, because we've thrown a lot of things at it, anything from Dr. Jace's rehab to our PA Josh's laser and just the rest of the team. I tell you what, I'm very grateful. So it's been a good recovery so far, and I hope to by April 1st be 100%. I'm going to push myself, so that's my goal.
That's cool,
Yep.
man. Yeah, and we're grateful to have you too.
Appreciate it, Doc.
Going through any injuries, not the most wanted, but I think you can get a lot of information out of it, especially the progression through. So we'll keep you guys updated the best we can as we keep going on that aspect. So as we're going from the bone structure to more the ligamentous structure, the tendons, the muscles, how everything communicates, I think is very important to have an understanding for not only function, but also the healing and recovery rate. So we're gonna start with the labrum, and that's where it's the next layer of tissues right on top of the bone structure. It houses of limitations of how you can move your arm. The shoulder labrum is the first line of communication back up to the brain. Now, where the nerves attach to goes through the joints, and the joints then kick up information from the nerves, goes to the spinal cord and gets kicked up to the brain without any delay. There's no play between interneurons. So more or less what I'm saying is the nervous system, as it goes to the spinal cord, does it communicate to an interneuron, slight delay, and then gets kicked up to the brain? However, with the joint, it goes straight to the spinal cord and up with no delay. So that is the first line of communication back down, which then, if there's a problem with the joint, it's going to cause overlying muscle tightness. So we have to start rehab from the deeper structures first. And the first thing lost with any joint, especially the shoulder and hips, is internal rotation. So when we go through this, a good test, and we're going to get to this in the end, is how far can you rotate your arm down pain-free, and how far can you rotate back? Same thing across the body, back and from. So if there is pain with that, and again, we're going to get into other rehab deals for the longevity of the shoulder, but you want to add in isometric contractions, you want to build up the range of motion, the mobility. Again, we're going to get to that later. So that's going to be one thing very, very important. Now, the other thing I found kind of fascinating was the bicipital groove. So there's a short and long head of the bicep. Now, the long head, that goes through this bicipital groove, and there's what's known as a transverse humeral ligament, which pretty much has a ligament that stabilizes that tendon as it goes over and around this groove and attaches back on the scapula. Now, if there is any blow to the shoulders, that ligament can become lax, thus the tendon can come in and out of the groove, which is way more common than a lot of people realize, especially if we're rounded our shoulders on a desk, common movements in front of us, common throwing actions, like pitchers notice this injury quite often. And I found this kind of fascinating. There's a I can't remember the ligament. It goes from the coracoid process all the way down and attaches right in front of the bicipital groove, and that also runs into that long head of the bicep tendon. So when you look at cadavers, when you look at models, there is a difference in discrepancy between certain tissues, but a lot of times everything kind of blends together. Now, the thought process with this is, yes, it may look like two different structures in a model, but in a human body, when everything is communicated and meshes and gels with one another really well, there's not any open space, if we will. I think that ligament runs to the tendon, and it's that juncture that can create a bunch of problems. Now, again, this is theorizing. I don't think there's any way that we can physically break this down unless we have an internal device monitoring that as we're living. There's no other way around it. We're definitely not there yet in technology, but that line of communication is incredibly important. There's different ways that you can go to adjust. A lot of times chiropractors, Doc, I'm sure you probably have done this before, this adjustment before, to where if you have your hand up higher on your torso and you bring your back of your elbow into the wall and you try to kick back as fast as you can, it can slide that tendon back into the groove.
Yep. And you'll know, I mean, a lot of the patients that come in with this is usually feeling pain on the anterior portion. They definitely feel as though there's something slipping, popping, or clicking. Mm-hmm. That's definitely an audible noise that they hear. For those of you that have either had it or are thinking that you have it, it's something that is more common than you think. So,
yes.
But yeah, absolutely.
Yeah, no, thank you. And again, I don't want you guys to just go and try a lot of this stuff yourself. I'm just giving context to the situation that it's rather simple to get back into place, but to restabilize and create elasticity and stiffness into the tendon, that is a whole different ballgame.
Yeah.
To restabilize your shoulder in that specific area long term. We can get into some of that as well and how we can bleed the muscle contraction or tissue contraction energy into specific structures of tendons, ligaments, which is different than how you can train joints and muscles. But I think that is something that we all have to pay attention to. Now, as we add on layers of muscle, as we add on other tissues, not only of the bicep, but also the tricep, there's also tissues that go from the rib cage to the shoulder blade, known as serratus anterior, and that controls a large portion of rounding the shoulders. That also has and can pinch off on different nerves going down to the arm and also down to the rib cage via contracture. So if you find yourself rounded position for longer periods of time, to open up the shoulder blade because of different structures of the shoulder girdle, we have to start at a few different areas. First off, the armpit houses a lot of different tissues which control internal and also certain ones that go into external rotation. There's also a muscle known as the latissimus dorsi, or known as the lats, which goes from the humerus to the rib cage down to the lower back, and that communicates the whole shoulders to the lower back pelvis. There's also tissues on the back side known as the rotator cuff muscles, which is broken down into the supraspinatus, infraspinatus, teres minor, and subscapularis. It's pretty much four main muscles which control internal, external rotation, and then a bunch of a variety of other movements, if we will. So when you look at any shoulder conditions, if you have shoulder pain, the complex of the structure is very diverse. So you have to look at many different tissues, from deeper structures to the overlying structures. How is the communication from the rib cage or below affecting the shoulders? How is the communication from the neck coming down as well? Because there's also other tissues from like the upper trapezius muscle, which goes from the neck, base of the skull, to the shoulder and then out from there. And there's different sections between upper, middle, and lower trapezius muscles. But when you look at the dynamics of movement, you want to be able to find a practitioner that understands all these different areas, and then what are modalities or what are other ways that you can be treated to help improve the function of the shoulder joint, to improve the function of the movement, whatever you find yourself in. And I think that'll give you the best bet. But like I said in previous other body series, I know Doc has said it many times before, we have to understand the deeper structures to understand what conditions or symptoms or problems can come from that. So you have a better understanding how to fix it, how to go and ask questions yourself.
I think,
please,
and sorry to cut you off, Doc,
no,
but
you're good. Perfect.
I think for a lot of people to understand what you just said, because what I'm listening to you and I'm like, man, that was awesome, by the way. Like the way you explain that, and I think people really do need to even go back and just re-listen to that. But what I think you need to take from that is this is such a complex joint. And as you were watching, you were seeing how Doc was pointing the shoulder and then pointing to a different part of the body, pointing to the shoulder and then a different part of the body. I mean, this thing was locked in and is locked in to so many other parts of your body. The lat goes all the way down to your middle back, even mid to lower back. And so this is something that does affect a large portion of your upper torso and body if there is inconsistencies with movement and strength of this area. And so when Doc was saying you need to find someone, you not only need to find someone who understands the changes and patterns that happen to a joint, but how to actually take a look and correct those. Because let's say for a rotator cuff injury, and we're actually going to jump right into that soon, what you'll find is that injury more than likely came from a poor pattern or dyskinesia, like we had kind of used that word before, but which really just means improper movement. That actually was laying down small insults to those tissues, but that final straw caused an injury. Very rarely was it something that, like in my case, I fell very hard onto an area and it broke and avulsed and tore. But most of the time it was because of improper motion, weakness, a lot of things that aren't picked up, but you go in to see a provider, especially obviously like an MD or surgeon, and they're thinking, oh, you got the rotator cuff, might as well get you, anchored, we'll do some surgery and we'll get you back. But what they sometimes don't take the time to realize was there was a long-standing inconsistency in how you moved that area way before it actually injured itself.
Yes.
And so Doc, I think, stated it beautifully. You have to understand how to catch those patterns, because if you don't, it'll happen again.
Yes.
And it's probably happening on the other side too. Too many times patients are like, yeah, I got this one done. I got to probably get this one done soon. You don't need it. It's not like you were put on this earth to need surgery. You absolutely do not need it. So I just wanted to kind of chime in off of you there.
And to even play this back to you as well too, like what he said was really important, that should be said probably 3 times. If you don't change the habits, you're gonna lead to the problem coming back.
So let's just talk quick first, Doc, on what are the main things that patients deal with when they have rotator cuff issues, and then we can kind of move on to typical treatments, what we feel is best, and then some of the research behind it. So Doc, what do you typically see in patients with rotator cuff, and what are they feeling?
Perfect. So yeah, rotator cuff usually comes in terms of tendinitis or tendinosis, and the difference between tendinitis and tendinosis has a degenerative quality to it. It usually comes in individuals older in life or individuals even early 30s on up, to where if there's a past surgery or if there's a really bad injury, the body is going to start laying down bone spurs. It's going to start creating bone from the cartilage, because either one, there hasn't been enough blood supply to the area, or the arm, it wasn't able to move in various directions to build up the viscosity of the joint. More or less, there hasn't been much communication between that joint and that area of range of motion. And if you're not able to move in that area, that's where the body will start breaking down. The body is incredibly smart to lay down tissue if it's not being able to utilize. But no, going back to tendinitis, tendinosis. Tendinitis is inflammation of the tendons, which often come from either pain, and depending on where the tendons are coming from, either could be most commonly tendinitis of the supraspinatus, which is the muscle on the top of the shoulder, which goes from the shoulder blade down to the humerus, and it controls lifting the arm up to 90 degrees. So if you having troubles or problems either lifting your arm up or you have to lean off to the side, that's where I would first look at. But if there's inflammation there, it's going to cause overlying muscle tightness. There's going to be some guarding. Now it's how can you get the tendonitis under control? And there's a few different ways you can go about that. Some of which either could be movement pain-free. To get the inflammation under control, you can use different aspects of medication. You can use heat, cold to get that under control. As you open up and the pain starts to diminish and there's less tightness, that's where you then want to go into longer lengthening, or starting with your arm off to the side and then slowly come back down to lengthen that tendon. But let's say there's tendonitis of the bicipital group. It's the same thing, but moving in the opposite direction as time goes on, as pain relieves and as tightness diminishes. Same thing with any of the other muscles. You have to understand what tissues are being affected and where is the tendonitis coming from. But there can also be snapping in the shoulders. There can also be guarding. There can be some like swelling. There's a bunch of different variations to this, and that's where you have to go see a practitioner. But I guess, Doc, what other things have you noticed with that? Is there a different test that you look for with tendonitis?
Absolutely.
What's your experience with that?
I do know one of the quickest ways you at home can tell if you have any tendonitis in the shoulder issues is the self-empty can test. And I actually figured out I had issues just with this test from a doc in Atlanta. And you start with your thumb facing up, and you're coming off at what I would call a 45-degree angle from the shoulder in comparison to your torso here. So as you come up, you're going to go all the way up, and then you're going to turn and you're going to push your thumb, and you're really going to try to get it 180 degrees down from where it was coming up. And if you found some tension, tenderness, or pain there, which I already have because of my injury, but on my MRI, it showed I had tendinosis of some of my rotator cuff muscles. Yeah, that's usually, I would say, a warning sign. It doesn't mean you tore anything. You don't have to be worried. But what it does give you is maybe some insight to, hey, you know, how have I been moving? Am I exercising? Am I lifting weights? What am I doing wrong? Have I been sedentary and not really moving my arms that much? Like, you'd think because I'm not doing much, it shouldn't put strain on the other parts of my body, but it actually does. The body does respond, like Doc said, when you're not moving that arm into full motion, it's just going to start building more bone and start to cause more degenerative processes. So movement is what can actually stop that. Oddly enough, it's a weird concept, but those are the things that you definitely need to make sure that you're doing, is moving into a fullest range of motion possible. But with the rotator cuff, what I would say is, there are many times where you probably have the ability to prevent a tear from happening and you've noticed it first. You just maybe didn't listen to yourself. I'm not going to throw numbers out there. Actually, I was going to, but I'm not. Let's say you're getting to that age now where you maybe had some kids and you've been into your jobs for a while and you maybe got out of the gym. You hit the weekend and you want to throw the ball around with some friends, your kids, what have you. They're a good 50 yards away and you open one up and you haven't thrown a ball in a long time and you're like, oh, okay, that one got me. There's a good chance that was probably your rotator cuff. It could have been other things, but that's more than likely what it was. And what that told you is that tissue was not ready for that load. And so when we talk about the patterns that we're trying to catch, and when we talk about just things that you need to keep an eye on, it's making sure that you can properly prevent all of these insults that are happening to that area before the tear actually happens. So the tests that I have for patients was the one that I showed you. Ones that we do in clinic usually is a drop arm test where we lift your arm and we drop it. And if you can't catch it, or if you try to catch it and it's extremely painful, that's usually a very high sign. Another one is just testing the muscles themselves. Doc and I can test each of the specific rotator cuff muscles, the 4 of them that he talked about. And if they're weak or you have the inability to use them, again, that's another sign. But with the things that we know that are really helpful for treating or taking care of rotator cuff, Doc, do you just want to jump in on how obviously exercise and PT can do such a great job with managing this?
God, yeah. Because if you don't use it, you lose it.
Yep.
And that
Beautiful.
principle takes place with any other structure in the body. So if you're not moving your arm back here, the body's not going to send resources to build up and to maintain those tissues, that movement. And as you add time and gravity, the body has no other way other than to create either atrophy or limitations to where if you don't move backwards in that direction, then you maybe get here, you maybe get here,
Yep.
and then it leads to other problems. It can lead to degenerative changes, and then other symptoms, problems can come from there. So when you go into exercise, when you go into physical therapy or therapeutic exercises, if you will, you have to be very specific, but if you get proper motion in all the joints, moving in many different ranges of motion, maybe not just lifting in those different ranges of motion, but creating the mobility, they can help maintain the structure long term. You just have to stay consistent with that. And I like what Doc said. It reminds me of my dad too, playing baseball. The image came in my mind at the exact one moment. I can even picture myself. I'm in the middle of a baseball field. He's on the corner line. And the same, almost it was like deja vu there for a second. So yeah.
Was that you or your dad?
My dad.
Or your
of
dad?
course,
Oh yeah.
I'm like, oh boy, something's going on. And going back to that point, if that does occur, but it gets better over time, you still want to go get that checked out.
Sure.
Because that can lead to degenerative changes long term. But
Yep.
yeah,
And it's less scary than you think.
Yeah.
And we're about to get into that
Yes.
shortly, but I just want to preface that. Doc's going to talk on the things we can do to obviously get it moving. I'm going to talk why surgery is usually a last chance, if not ever needed. So
yeah, just even to dive into that next point, there was a study by Cahoon et al. In 2013, and it showed the effectiveness between physical therapy in treating atraumatic full thickness rotator cuff tear, which just means that it wasn't a traumatic incident which caused the tear. It just happened over time. So they looked at physical therapy versus having surgery. It looked like that they had similar results between surgery and or PT, which suggests that you probably want multiple opinions going to surgery if it even is needed.
Yep.
And I know there's a few other studies that say that very similar aspect. Doc's going to get to that here in a second, but I think my takeaway with that is after you have the surgery, it doesn't necessarily fix the problem. It can fix the structures underlying it, but if you don't have the proper communication and maintenance of that shoulder long term, if you don't have the knowledge to work out certain tissues or go through the biggest range of motion possible, like I said, it's either you use it or you lose it, and the body's not going to maintain it, even if you've had surgery. But yeah, Doc, I guess any other points to that with the surgery?
No, that's kind of what I wanted to hit on with rotator cuff. Obviously, your study concluded surgery versus non-surgical, which is what I always love sharing. I think what people don't realize, and I'm going to quiz Doc and see if he can guess this right, but they did a cadaver study, Doc, okay? They did a cadaver study, and they showed out of this, I think it was 600 cadavers, they were aged between, I think it was 60 to 80 years old. What % of them had a torn supraspinatus tissue? And they had reported that these 60 to 80-year-olds never had a history of what they concluded was a shoulder injury or tear in their medical history. But after doing the research on these cadavers, between 60 to 80, what % of them had a torn supraspinatus tendon?
I would estimate 60%.
Yep. So it was between, their range, because they couldn't quite conclude full versus partial, but it was between 60 to 80%.
Oh, dude, that's crazy.
Yes. And what they also found was, in some studies, you have I call it the decade rule, where at 50 years old, there's a 50% chance that your supraspinatus tendon is already torn.
Fascinating.
60 is 60, 70, 80 is 80. It's plus or minus 10%, but like that's about how much of a chance you have to tearing your supraspinatus tendon. Now, when I look at this, and I know that other people are thinking, well, when you tear something, then you want to get it repaired. But when I look at this, what I see is we had patients that had no idea that it was tore, and they went about their daily life. And more than likely, the pain either went away or it subsided to a point that was manageable. Had they actually got proper rehab and did what they did, they probably would have taken most of that pain away and had a pretty good restoration of function. But what you'll find is there is such a high chance that this injury will happen just from statistics alone, observational studies. And more often than not, some of these patients didn't even realize that it was torn. So for me, when I'm seeing and hearing when I read all of this is just something that is going to happen to me. I'm just going to conclude that as I continue to be on this earth, eventually it will probably happen. And if that's not just a sign of normal aging, then I'm gonna disagree with everyone out there who says as you tear your rotator cuff, you should get it surgically managed. Now, when I talk about these studies, musculoskeletally, what we find is surgery musculoskeletally almost always, in very few times, performs just as good as PT or exercise, concluding 1 to 2 years. You pick a joint or something musculoskeletally, there is research out there showing surgery did just as good. Yes. More often than not. Now, if we're talking like a full joint replacement, that's different. But musculoskeletal tendinopathy, for tendinopathies, I bet you across the board, surgery and PT do just as good in research. Yeah. So what I really am trying to conclude is it's a normal process. Eventually, if it does happen, it's not something that you should be worried about. And surgically versus non-surgically, you're going to have the same outcome. So I don't think you need to even jump to something that's that invasive.
That's a really good point. Like, we're treating tendons, which is pretty much a connection between muscle and bone. And if you can treat that without surgery, there's way less risk of any other problems going down the road. So, yeah.
And I'm so enthused that I don't have to have surgery, because I knew what such an uphill battle it was going to be and probably affect the rest of my life. And especially as someone who needs these shoulders and arms to do my job, it was very worrisome for me. So that's just how I want you guys to think about taking that and making that decision, and just thinking, what is it going to do to me long term? And unfortunately, and not to say that all surgeons do this, but unfortunately, some of them don't sit down and give you that expectation in the long term. They're thinking, yes, I understand you're in pain. Yes, I know that you have this injury. Let's get it taken care of so you can feel better. Not to say that some don't, but some, what they should have said is, hey, yes, I'm going to take care of this, but now just so you know, we now have a weakened structure because I did an invasive procedure on you, and it's going to change you over time unless you do proper rehab to take care of that. I think that's the education that should be done. Does it happen all the time? No, but that's why we're here talking to you today, so that you realize just what to expect when that happens.
Absolutely. So as we're looking from like the surgical route to PT, let's also look at the newer age rehab coming to fruition, known as like plasma or platelet therapy. I know Doc has an awesome history working with multiple providers on this one. I guess, Doc, I know there's a study that you've brought up. I guess, what's your take on that?
Yeah, absolutely. And I think PRP is something that is going to be used even more frequently. It's now probably in every orthopedic pain clinic out there. It has enough research behind it to show efficacy. When it starts to hit the modern medical system, it shows that there's been enough research to have that take on, which is a good thing. It is a good thing as long as it's done properly. But PRP, the concept is your blood is drawn into these vials, and then it is spun down in a centrifuge, and the plasma is then separated from your red blood cells, among other things. So what they do is they draw out the plasma, which is full of platelets, which is why they call it platelet-rich plasma.
PRP.
And they then take that and they can inject it into certain areas. What plasma is full of, again, is platelets, and platelets are really helpful to heal up injuries. And it's the first thing that is a part of the inflammatory process, is the formation and arrival of platelets to an area. So when we can hyperconcentrate these platelets and put them in an area where healing is necessary, it does a phenomenal job at increasing your ability to regenerate and recover, especially from tendinopathy tears, those kinds of things. So the study that Doc was talking about was It's 40 patients. They did PRP versus saline, and so that's the control. PRP showed to have decrease in pain, improving function, and just a longer outcome versus saline. So what you're going to find is there are now ways to increase your ability to recover over time, just aside from all the other things you can do, exercise and PT, and that's something that I think is only going to improve as we see medical science take off as far as technology goes.
I think that's so cool. And a question that came in my mind, if I haven't heard of PRP, but it's been brought up to me by a doctor, I have an injury going on, I guess, how do they go specifically and use PRP on a specific structure? Like, is it via needle? Do they use a camera? Like, how does that specifically work?
Good question. So for those who have a joint injection with PRP, they're going to need ultrasound where they can view the actual arrival of the needle into that area. If, for example, they are trying to place it into a specific structure, then they'll probably would have gotten MRI results prior to know where specifically they want to place it. There are also ultrasound units out there that can pick up certain tissues, and they can then figure out where the change in structure tissue is. So a lot of it is ultrasound based if you're taking the proper system to do this. And why I said those of you that are for those that are doing it out there properly, what I mean by that is ultrasound guided is the gold standard to make sure that you're putting it where it's needed. So when you think about that, it's more along the lines of if you have a supraspinatus tear, more often than not, it's at the musculotendinous junction. It's right where the tendon meets the muscle belly. But with each person, it's different. There could be tears right at the site where it attaches to the bone. It could be towards the belly. And so when you take and run the ultrasound over it, you can see the actual tissue changes. So that's
cool.
That's where they can go and put it right where it's needed. Now, the beautiful thing about PRP is I'm trying not to get down into a rabbit hole of other things, but it actually contains other things like growth factors. Your body actually has its own stem cells and exosomes in that.
Cool.
And people don't really realize that. Wow. So when you take a huge, large amount of plasma, it already contains your body's own stem cells and exosomes in it as well. So when you put that in that area, it actually has the ability to migrate. So you don't necessarily have to have it perfectly around it. Stem cells and exosomes have the ability to migrate around tissues. So it can get to the area it needed to as long as it's really in close proximity. So before I jump on stem cells and exosomes, because I do want that to be another podcast, where they put it necessarily isn't as important as for PRP. It's making sure that you have enough platelets to do the job. That's, in my opinion, they're going to be the most important thing. And then two, making sure that you understand the ratios of concentration to someone's age, also all the underlying risk factors that they have as far as their age, what medications they're taking, just as far as their health alone. There are times where they might be taking a blood thinner, and so that plasma structure is going to change. There are even times where a lot of doctors were choosing not to do PRP for those who just got the COVID vaccine, because they were showing drastic changes in the plasma content.
Wow.
Now again, I don't want to get down that rabbit hole, but there are ways to make sure that you have a healthy plasma aggregate before you do that. And a lot of these orthopedic clinics, they do a pretty good job as long as you ask them those questions.
That's so fascinating. I had no idea. And I got a chance to sit in firsthand at Saguaro Pain Clinic, which is right across the street over here.
Shout out to Saguaro.
Woo! Yeah, they're in Arizona. I don't know if they're in other states, but they're awesome individuals. I got a chance to see them doing PRP on an individual. It wasn't the shoulder. I think it was the lower back hip.
Yep.
And they had this huge, cool machine. I think it was a specific MRI ultrasound.
Was it a fluoroscopy?
It was for imaging, so they could see where they're going in at.
Okay. Was it like a big arm?
Yeah, that swings around.
Yeah, so that's a fluoroscopy unit.
Okay, cool.
And it's, to make sense, it's really just a motion x-ray unit.
Okay.
Yeah, so it's super nice because you can get to do x-rays in in live time, which I do think,
Man, that's
I
so
do
cool.
think moving forward in like the next 5 to 10 years, some of these like really advanced pain and or like integrative clinics are going to use like flexion extension for
Yeah.
injuries,
Or
like in a car
whiplash,
accident.
yeah.
What they're finding, and for those of you watching, we're geeking out right now, but when someone gets in a car accident, there's a good chance that there might have been a sprain, strain, or even a tear of the ligaments around the neck. And what we do is called a flexion extension view, and it's a shot of the neck when you're fully flexed and fully extended. And what that can show is there translation of these bones? And if there is, that's a good sign that there was unfortunately a injury to the very crucial ligaments that sustain the cervical spine. But we only take 2 images, so we can only see a picture of the flexion, a picture of the extension. What the fluoroscopy can do is take pictures simultaneously while you are moving, and you get to see that translation in real time, which to me is obviously going to just be way more effective. And just some of the other things that I know, as I can already tell Doc's wheels are spinning, just some of the things that you can view real time when it comes to instability of an area.
Yes.
You know, what does that scapula look like while you're trying to move it in as far as the x-ray goes? You know, the instability of the AC joint as you move it, how much translation of the bones, like these are all things that I think would be really cool to have. Unfortunately, you know, it's like a $150,000 unit, but I do think there would be great use for it if you could start to really dive in specifically to those tissues. But
Absolutely. Yeah, and where my mind went with that, same thing. I would love to have one, because anytime you go into injury, you have to rehab in that same exact area, thus so you can rehab the specific tissues that got blown out. But yeah, no,
yeah.
I would love to have one, man. But you know, I thought that was super cool. Like when they were going and doing the PRP, that you could see, and they would watch the needle go in, so they could see the specific structures that were affected. So the serum, the platelets were able to go in the right spot. And I think, as like Doc said, as the time goes on, adding 5, 10, 20 years, we're hoping that these technologies become much cheaper, thus so they're able to be used widespread.
Maybe even covered by insurance. There are times where now they're starting to, but it's taken some time. So next up, shoulder impingement. This is one that I think is another way for patients at home to very quickly and easily know what's going on. That's usually when you're lifting your arm all the way up and you have some pain at the top of the shoulder. Doc, quickly, shoulder impingement, what are some things patients notice and what are some of their symptoms?
Yeah, no, that's a good point. And when you look at shoulder impingement, typically the structures that are affected are the acromion, which is the bone on the top portion of the shoulder, and that connection between the humerus or your upper arm bone. And if that space is limited on the outside, it can cause pain when you lift your arm up, whether it's to 90 degrees, whether it's past 90 degrees. That's where there would be problems. There could also lead to a bursitis, because there's a bursa that goes out, especially from the supraspinatus, which is a muscle on the top of the shoulder blade and connects to the humerus. And it's that little area to where even if the humerus or your upper arm bone gets translated outwards, thus limiting this portion and space on the outside of the shoulder, that will lead to problems either pinching off of the bursa, the tendons, the capsule, the labrum. It can lead to even swelling, pain. It can lead to radiation of pain going down to the arm. Oftentimes comes from excessive throwing motions, or you're falling on your arm backwards, or repetitive motions raising your arm up and down. But yeah,
and I find that, and this is kind of back to what we were talking about before, but when there is a really heavy breakdown in the scapulothoracic rhythm, or excuse me, the scapular-humeral rhythm, that is a huge precursor to impingement, just because there isn't great translation of the scapula backwards to help, again, lift that clavicle off the humeral head where you're starting to move into abduction. So I always look there right away. I even find that if I can take with my hand and I actually move their scapula for them, and I can even try to translate part of the AC joint as well, you'll find that that pain is alleviated. So that tells me more often than not that we have some form of impingement. Now, Doc, what are maybe a couple structures that are usually the common cause of impingement, or what's actually causing the impingement in your experience?
Yeah, it's either going to be the bursa, which is inflamed, thus limiting the space on the outside. It's either going to be swelling, tendons or tendonitis, going back to the rotator cuff tendonitis. That would also cause it to be impacted. It could also even be problems or labral tissues on the inside portion of the shoulder, thus forcing the humerus or your upper arm to get translate outwards, thus also causing pinching. Is just where that root cause is coming from. It was actually a really good point for Doc to bring up how the connection between the shoulder blade and upper arm move in unison with one another.
Just so you guys know, there's a lot of things that can cause pain if you abduct.
Yes.
So we want to make sure that you guys understand our several things that it could be. So if you've heard of us talking over the time and you're listening to us, I know how fun it is to self-diagnose, but just let a professional check it out first before you start making any advancements into what you think is going on. But I do appreciate if you guys are out there thinking that we're diagnosing you as you're listening to this podcast, but we can't do that. And we wish we were that good, but no doctor is that good, unfortunately, that can diagnose just a podcast listening to you. So anyway, Doc, how good is PT or exercise for shoulder impingement?
Yes, so it can help out significantly. There's a study that I had, a randomized control trial by Bain et al. In 2017 that demonstrated the effectiveness of a multimodal physical therapy program, which involves massage therapy work, exercises, and it just showed improvement of function and decreased pain on the impingement site itself. Now with that, again, it's how can we relieve the pinching on the outside portion, and understanding and knowing that that's even the problem, or is the problem coming from somewhere else? So I think that's where you first want to start. But no, this study showed everything pretty darn well that stated that PT muscle work over a period of time can improve the symptoms of not only pain, but also the function of even lifting your arm up in ranges of motion too.
Beautiful.
So, yeah.
And when I found the difference between surgical and non-surgical for shoulder impingement, they do something called an arthroscopic acromioplasty, where they file down a part of your shoulder to kind of help with that impingement. And over a 2-year period, surgical versus non-surgical, there was no change in outcomes. So what that means is the non-surgical portion of patients did just as well as the surgical. So again, is that invasiveness needed? Apparently not in this study. So again, we're just going to reiterate, when you take musculoskeletal issues, very rarely is surgery just as good, if not the same as exercise and PT. So
That's a good point. Yeah. Which, shocker.
So moving on to frozen shoulder, Doc. I know this is one that's super scary. A lot of patients feel like it's been just nonstop for even months to years. This thing can set in and it doesn't have a lot of change. So what are some things people present with frozen shoulder, and what are the kind of stages of it, and why is it such a tricky condition for patients to deal with?
Yeah, tricky because we don't necessarily know the root cause for most people.
Yeah.
It can come from not utilizing the arm, shoulder to increase the range of motion, especially after surgery or after procedures that have been done around the area of the shoulder girdle. It can lead to a few different things of pain, stiffness, lack of range of motion, but it comes in pretty much 3 stages. It's either going to be freezing, frozen, or it's going to be thawed. So, and this can last over, like Doc said, several months to even years. So when you have this and you start noticing over time the pain's getting worse, over time you're losing range of motion, that's a key indicator for me of, okay, we're more than likely dealing with a frozen shoulder. And frozen shoulder is a fancy term for adhesive capsulitis, to where the capsule, especially of the labrum, starts to inflame and it leads to guarding overlying it. Thus, like I said, if there's any problems with the shoulder joint, At the joint level, it's going to cause overlying muscle guarding, thus why it's really hard to improve this. But this is very common in individuals, especially women more than men, ages between 40 to 60 years old. Oftentimes, if you, like I said, if you have wear and tear in the shoulder, it can lead to that capsule become inflamed, and once it becomes inflamed, it can lead to more widespread, thus take on the frozen shoulder. In terms of the treatments, and we're going to get back into some of the symptomology here in a hot sec, but there's something that I found that was kind of fascinating. It's called hydrodilation combined with physical therapy. It's hyaluronic acid injected into the capsule, also with ultrasound. And then you add physical therapy or movements to this. So I think of it as we get fluid into the joint and you allow the body to mobilize or go through the fullest ranges of motion, or you build up the rotator cuff muscles so you can send a signal to the nervous system to heal the tissues. And then also, as you're going through the wider areas of the ranges of motion, it's going to allow some of the synovial of the joint capsule to pick up the waste products to filter that out, thus help in the inflammation stages. There's an awesome study, a systematic review by Buchbinder et al. In 2014, which showed an analysis of several randomized control trials that found that hydrolation involved with also physical therapy has been more effective than just physical therapy alone to increase range of motion and decrease pain.
That's interesting.
So I think when we get fluid into that area, it's going to allow greater range of motion movement, but it's also going to allow some cushion to take pressure off the labral tissue and off the inflammation, thus so the body can heal it much better. But I guess, Doc, is there any other things, experiences that you've had with people with frozen shoulder? Is there any studies that you've seen, surgical, non-surgical, or what have you seen with frozen shoulder?
So I think, and this is coming from a prior history of working with functional medicine doctors who take a look at blood lab work and really do a great job of making sure we make lifestyle changes upon viewing those. So supplemental intake, change in diet, those kinds of things. And what we found is we theorized that frozen shoulder kind of had a systemic effect. It was from a systemic effect. We found that it might have even been correlated. We found a lot of patients who had autoimmune issues had frozen shoulders.
Good point.
So now this is, again, a theory. I'm not sure if there's research on it or not. I haven't even looked that up. But what we found a lot was it was women, a lot of women, like Doc said, women who had autoimmune issues had these frozen shoulders. And what we found was when we took their blood work, and of course, it was, different between each person's blood work, but when we tried to make more lifestyle changes, better diet, try to reduce inflammation, a lot of their pain and range of motion improved. Not to say we weren't doing chiropractic and manual therapy at the same time, but we found it was a game changer when we could have them agree to making those changes. I do know another common thing that people use is what's called mobilization under anesthesia.
Yeah, that's a good point.
Where a lot of the times when we're doing PT to a frozen shoulder, it's very uncomfortable. And there's a lot, like Doc said, there's a lot of guarding. So what they do is they put you under anesthesia, and then now they're able to kind of more aggressively move your shoulder through fuller range of motion. And like Doc's been saying this whole time, the more motion we have, the better it's going to be. But if we are trying to sit and pin you down to move your shoulder as you're awake and it's just so painful, we're not going to get much.
Exactly.
And that's where if we put you under, that guarding is now gone. We can then create greater change while you are sleeping, and then when you're awake, we can then try to make improved motion, and the brain will pick that up, and it'll actually be able to then say, hey, we're making changes here. I maybe don't have to guard as much. And it's crazy how the brain creates all of these changes simultaneously at the same time when you are doing these kinds of things. But I noticed MUE, it's called, is very effective. If not, Shockwave, it was another thing that we did a lot in clinic that made really good changes. Shockwave, for those who don't know, it's a device that creates sound waves to help break up adhesions, to help improve blood flow, to generate stimulatory changes for healing. And yeah, it was a really great way to loosen up the tissue. I think what it also did was it can penetrate really deep with this treatment. So, like Doc said, that the adhesions and change around the capsule is where a lot of that needed to be done, and it's tough for providers to drive with their own hands or even tools to get that deep or even make those changes. So this was something that, again, technology can do to really get to those areas that the stiffness is being caused from. But yeah.
That's beautiful. And yeah, I didn't even realize, autoimmune makes way more sense. And then even anesthesia.
Yep.
Yeah.
But lastly, we go into shoulder osteoarthritis, which I think is going to be one of the biggest ones that we see. And Doc, do you just want to jump into what patients usually are dealing with when they have arthritis of the shoulder, and what does that presentation look like?
Yeah, so it comes in individuals later on in life, or like I said, if you've had past surgeries and you're not able to move into different ranges of motion, the body's going to lay you down bone spurs from the cartilage off of the humerus, or that ball joint, if we will, and that'll lead to limitations of movement. It'll lead to pain. It can have a lot of guarding, stiffness, tightness. Now, there are ways that you can improve the condition, but if it leads the body going to bone spurs, there's not much you can do other than to have surgical intervention or shoulder replacement, because if the space is limited, it's going to only impact the tissues around it, but there's only so much you can do to pump up that space. It's pretty much comes with weight-bearing activities over periods of time, often can come from repetitive movements over time, like whether that's a baseball pitcher doing the same movement over and over again, and it can lead to guarding around the area, not only in the common movements, but either on the inside or outside portion of the shoulder. But yeah, it's often overuse. There could be some grinding, weakness, instability with certain movements, especially if you come into extension, start with rotation inwards or thumb going downwards. That's a really common presentation, but oftentimes can be seen and picked up via x-rays or imaging as well. But yeah.
With OA, just like any joint, it's going to happen symmetrically for most of the time, unless you are the type of person that has been using their arm drastically different between the other arm. But aging and degeneration tends to be symmetrical, so you'll see it pretty similarly either in the hips, especially in the hips and the shoulders, because as ball and sockets, they tend to shrink in space together. So, but what'll happen is it'll get to a point where you won't have any more motion because, again, there's no more space, like Doc said. But not only that, the body's reaction to that is to try to fuse it and build bone, and that is very painful. So what will happen eventually is, yes, surgery is going to be an option, and there are times where I'm not afraid to make that call because your quality of life has gone down so much from just how drastic arthritis can make changes to the joint. But unfortunately, when you get shoulder replacement surgery, it is super invasive and you are heavily limited on how much weight you can put on that shoulder now. And it sucks. It really does. As far as outcomes, I do know that right now surgery is winning versus PT on a lot of end stage arthritis for shoulder. It tends to do better in the 1 to 2 year outcomes. However, for me, it's still now the fact of, okay, you're going to have better quality of life, absolutely get it done, but just know you may not even be able to put more than 30, 40 pounds on that prosthesis. And that is tough if you want to continue to lift heavy things and do things and feel like you want to, dominate that part of your life. But again, if you just want quality of life, then absolutely, I think surgery is going to be a necessity. It just depends on the severity of the arthritis. But
yes, and there's a couple case studies, one of which that comes to my mind. A patient came in, she wasn't able to move her arm. We knew that the space was very, very limited in that ball and socket joint. And through physical therapy, through massage work, through chiropractic, through specific rehab exercises, we were able to increase the range of motion and open up her shoulder capsule about 1 to 2 millimeters, which decreased pain, improved range of motion, significantly, but she still has limited range of motion of her arm coming up and around. We were more concerned, in addition to increasing range of motion, decreasing pain, that the structures of her neck, mid-back, lower back, rib cage weren't affecting and compensating. So we prevented surgery, but like Doc said, there's limitations, and if you're not able to buy in to a specific program that can help build up those tissues and build up that capsule, surgery might be the best route for you.
Yeah.
And that's where you got to get multiple opinions. If there isn't any other multidisciplinary treatments or places that can help with that, depending on where you live, that's a route that you might have to go via surgery. But yeah, I think that's
things at home. We're going to get to this in a little bit too, of things to improve. But when it comes to arthritis, there are a lot of things that I think people hear, especially like, oh, my father had it, I'm going to get it kind of thing. Or even, oh, I was tough on myself and that's just what happened. But it's more preventative than you think. It's way more preventative than you think. So don't let those be excuses for you to continue to degenerate.
Yes.
That's all I'm going to say.
And we've seen individuals in their 80s, 90s with hips that have close to full enough space in between.
Yep.
Same thing with shoulders. If you can maintain your structure via movement, whether it's yoga, tai chi, other practices that you're moving your body, the body will maintain its structure long term.
Yep.
So that has been shown. So a lot of times it is not genetic, it is common tendencies you pick up either from your parents or family or people around you that you adapt into. So there's the environmental factor. But
diet as well. I mean, many things. Many things. So lastly, we have scapular dyskinesis. And dyskinesis is just a fancy term for inability to move properly. So, or a kind of a breakdown in movement. This is kind of one that I'm excited to talk about because I don't think it's talked about enough, and I think it's missed a lot, Doc. I don't know about you, but what are some things people deal with, Doc, and how does it present?
Yeah, shoulder dyskinesis, that's a mismovement of your shoulder blade on top of your rib cage and how well that can communicate with your upper arm. So, for example, when we want to make sure certain joints are moving properly, especially between the scapulothoracic joint, which is the joint between the shoulder blade and the rib cage, if that isn't moving properly in all ranges of motion, it can lead to compensations, or what we often see is winging of the scapula or shoulder blade to where it comes off to the side. It could be on both, it could be one versus the other. Oftentimes it's one side versus the other instead of both via compensations.
And what Doc means by winging, and this is a great way for you to have a visual of what that means, but I know you have a friend out there who has shown you that they have the ability to make their scapula look like wings or push out behind them, and it looks as though they have two jutting bones coming out of their back. It is a cool party trick if you have that amount of movement in your scapula.
Yes.
But what you need to tell that person is they are so predisposed to injury if they do not get that under wraps. So that is winging. It's when the scapulas can jut so far back away from your spine. And that is, yes, it's funny looking and it's comical, maybe a fun party trick, but it now puts you at such a greater risk of injury to your shoulder because of it. What it means is there's instability and weakness to the tissues that should keep that scapula down, so you're not able to do that.
We often see, from a practitioner's standpoint, we want to see how well the upper arm or this ball and socket joint can move indifferent and apart from the shoulder blades. So oftentimes, and we're going to get into this here, how well can you bring your shoulder blades together and then move your arm so you can know the disconnect between these two? Because if they're moving together, oftentimes that's going to present in this shoulder dyskinesis or this scapular winging. Yeah, because if they move together instead of indifferent from one another, it has a huge tendency to cause that impingement syndrome on the outside portion. There's a fact, even a study, 2016 by McClure et al., back in the Journal of Orthopedic and Sports Physical Therapy in 2006, it pretty much showed that there was an exercise program between targeting scapular kinematics or how well the scapular shoulder blade can move in combination with shoulder impingement syndrome. And the results showed improvements of the scapular motion, improved the impingement syndrome. So
just working on the scapula
Yeah.
actually improved the shoulder pain, which
Yeah.
again, underlying things, you got to know those patterns. You got to pick up
Exactly.
those. You got to be able to pick up those patterns.
absolutely.
And that's actually what the study I had given was. Basically, they took a huge panel and summit, and they were trying to understand each of the researchers' implications for scapular dyskinesis. And what everyone really brought to the table during this was a huge, huge consensus statement saying the main importance of treating scapular dyskinesis was actually the identification and contributing factors versus treatment itself. I mean, they were saying that the most important part of treating it is actually making sure you know that it's happening because it's such a specific tailored treatment plan when you're trying to treat scapular dyskinesis that if you're kind of shooting in the dark, there's a good chance you're missing. And that's where a very thorough breakdown exam, making sure that you understand how the shoulder moves aside from the scapula, is going to be key to picking out those inconsistencies.
It's how well your body can move from joint specific, but also movement as a whole, which is perfect. And now going into other modalities, and I think we're grateful enough in our clinic to have what's known as a laser, a low-level laser. It can improve so many symptoms, especially of the shoulder. And I know Doc's going to talk here in a sec on how well just even laser therapy can improve other shoulder conditions. And I know you've had a lot of experience with this.
Yeah.
So Doc, I guess what's your take on laser with shoulder conditions?
So the reason I wanted to add this in at the end was because we are doing laser therapy now at the clinic, and Doc and I have both seen just such great changes in patient results, and quite quickly. Like, we've been amazed at just how quickly, even after one session, it can make great changes to range of motion and just function improvement. So quickly, I'm not going to get too specific into what laser, all the science behind it, but basically it can be a mixture or just one frequency of light where it's shined at the area, and over time it can maybe anywhere from a 5 to 15, maybe even longer minute treatment. There is physiological change happening cellularly, and what you're seeing is just a uptick in the ability to heal. You're seeing vasodilation changes, blood flow changes, and kind of a cascade of processes that are getting started to change and create healing. So what the cool thing is it's incredibly safe, by far probably even one of the safest treatments out there.
Oh, yeah.
It has, I believe, the laser we're using has 23 of the 24 FDA cleared approvals for its classification. So you're literally, the FDA has pretty much signed off on everything that you can do with this laser. And it just, again, shows just its safety. But not only that, research shows with this one study was basically a review of what's called photobiomodulation therapy, another name for laser, in the treatment of shoulder pain. So it took a look at rotator cuff, it took a look at frozen shoulder, impingement, pretty much everything that we talked about today. And it stated that photobiomodulation therapy or laser provided significant pain relief and functional improvement in each of those conditions. So again, we want to make sure that we continue to talk on just all the other things out there that you can do and try before you either do cortisone injections or you do surgery, take medication. I mean, when I tell you we are seeing change in one session, I'm not saying it to get you, I'm not expecting 50 of you to call in and do lasers with us tomorrow. That's not what I'm not trying to flex on you. I'm saying we are seeing changes in one visit, and patients are ecstatic. And some of these patients haven't seen that kind of change in weeks just because of how severe these issues are. So when I talk about this, I can also state laser is actually helpful for other areas of the body too, but this is just a time I kind of wanted to introduce this because we are doing it and it's getting great results.
Oh my gosh. Yeah, there's many individuals, and we're going to have Josh, our PA, a physician's assistant, come in and talk to us on a guest series coming up here, and go in depth on some of the results. But just to speak on one, it comes to my mind so clearly. This individual, she wasn't able to lift her arm up. She had pain on the front side after, God, I think it was like 5 to 10 minutes of this laser, one session. She was able to move her arm up. She was like, I don't know what this voodoo magic is, but I'm digging it.
Reach up. That's about as far as you can get.
Yeah, that's like...
It's stuck.
Yeah.
All right, how about like rotation?
It's very limited.
Okay. All right.
It's very stuck.
Okay, so we'll do the laser on the shoulder blade. So it's stuck. Go ahead and extend your arm now. Wow, such a difference.
Yeah.
And rotate.
Yep.
Wow.
So
And
there's many more, but
I'm also a case study. Like,
yes.
I will fully state that my progress would not have been as quick had I not been able to have the laser. I fully believe that. And so yeah, it's a beautiful machine, and super grateful that we have the opportunity to help patients with it.
That's beautiful.
So lastly, Doc, I know you had talked about how when the shoulder and the scapula do not move appropriately, or like you said, when they tend to mimic each other and move together, there's a lot of breakdowns and changes in compensatory patterns. What are some ways that patients themselves can take apart and know how the glenohumeral joint should move versus the scapular joint, and what kind of motion can they practice as far as tools at home?
Yeah, and this is the assessment portion. This is how you can build up and train your joint capsule. And then I'm also going to explain, different from any of the other series thus far, the stages and levels and how that can be trained. So when we're looking at rehabbing any conditions of the shoulder or rebuilding the shoulder joint, whether you're in pain or not, or just want to improve range of motion, improve the functionality, we want to see how well this joint, this glenohumeral joint, this ball and socket joint, how well that can move throughout the biggest range of motion possible. One, it's going to give us a good assessment on where there's limitations. And then two, at the same time, we're going to be also going into the rehab or the movement itself. So when you go into this, we want to make sure, like I said, we are isolating the ball and socket joint. So that's going to involve us keeping our torso contracted, ideally keeping our shoulder blades a little bit together. And in order to go through the fullest range of motion, we're going to have to also make sure our arm is completely straight, so we're not bending the arm during this movement. So when we go through this, we want to start palm facing upwards. Our palms can be open, it can be a fist, it doesn't matter too much. We're going to go nice, slow, nice, easy movement all the way up to the neck, head. From there, start to turn the thumb towards your head, and then so it's facing forward. And then we can start to rotate backwards. Keep rotating, rotating, rotating until you can't anymore. And then from there, slide the arm inwards as the thumb is facing away from you. And then back down. Same thing, opposite direction, thumb facing backwards first, and then start to rotate back and around. Nice, easy movement. If you notice popping, especially on the outside 2/3, oftentimes that's a tendon going over bone. Now you can improve the glide so that it doesn't pop. So right in that area to where if you do notice popping, go up to a wall, hold pressure, kind of like a stretching motion, nothing too intense. There shouldn't be pain with this. And put light contraction of your arm into the wall and off the wall for about 5 to 10 seconds. And then go through the movement again, all the way back and around. Now, if you notice sharp pain, come up and around and continue from there. If you notice limitations to where I can only move my arm like yay, or if you start noticing your arm and you have to hike your shoulder up, keep the shoulder down and then go through that range of motion. So you're isolating that joint. Now, it can build up in stages. So level 1 is nice, easy, light movement. There shouldn't be any pain with this. It should be pretty simple. Level 2 is pushing that line of tightness. So I can't move any farther over because of the guarding tension. And spending as much time as you possibly can around that tightness will improve the capsule, will improve how much fluid gets to the edge portion of the joints, thus so you can help heal the edges and other areas that oftentimes you don't spend time in. Now, level 3 is a few weeks, if not a month, after you spend time in level 2, and that's where you hold weight on your arm or holding a dumbbell, starting off maybe 3 to 5 pounds and building up from there. I'm at right now to where I can only move about 20 pounds. I can only move 20 pounds in a circle right here. It's how well you can control the range of motion against gravity over time. Now, that is going to be different than how you can train your scapula, the scapulothoracic joint between the shoulder blade and rib cage. And that, like I said, is isolating that joint. So we can do this a few different ways, keeping the arm completely straight. Same thing with the torso. However, we want movement of the shoulder blade. So you can first start off by reaching forward, shrugging up, big circle back down. Key portion for everyone is bringing shoulder blade back down and then forward, and from there. Opposite direction, depress your shoulder down, shoulder blades together, shrug up, and then reach forward. Same thing, level 1, 2, 3, nice easy movement, both directions. Level 2, spending more time around that line of tightness as often as you possibly can. And then 3, you can either do it by holding weight in front of you, or, which works better for most people, is you're in like a pulling stance to where you're holding a weight and you're doing the same motion movement back around both directions. Now, for most people, because we spend so much time in front of us, we want to make sure that the shoulder blade is moving back and down. This will also improve if you have shoulder dyskinesis or scapular weaning, to increase as much time as you possibly can of your shoulder blade back and down and holding upwards of a minute straight to build up type 1 muscle fibers. And then as you add weights, you can build up type 2. I'm not going to get into that too much. So that's just improving the joint capsules and the joints themselves. Now, in order to create health of the whole shoulder girdle, shoulder joint, pain-free, exercise, pain-free range of motion, it encompasses a lot of different movements. Movements off to the side, it can be cable pulls, it can be work on proprioception of how well your arms can move different from one another. It can be balance work of single arm and you move your body, overhead work with bouncing a ball on the wall and back and around. It's how well you can move your arm in any direction possible, pain-free. But if you want to add in more specifics, like let's say you want to improve performance of an athlete, depending on whatever sport, you want to know what movements you're commonly set in or what movements you want to adapt or acquire skill development-wise, and then work on transition of those movements and combine those movements together to create a sequence of actions, whatever your sport requires. So those are some of the basic ones that you can improve the quality of range of motion, the quality of pain, and build up your shoulder girdle. But
couple things,
please,
Doc. I think number one, people at home need to know, probably good to do it with a mirror.
Yeah, good point.
You know, I think a lot of people were watching you and they're like, oh, how is it moving that well? And again, we work on this a lot. So we show this a lot to patients. So this is something that we've obviously adapted to over time, knowing how to do. But if you're just starting off, you might want to watch yourself in a mirror because you might not be able to, at first, engage the tissues the way that we are. And we want to make sure that you just start out being able to focus on that. Number two, I know there's a lot of overachievers out there, Doc. And so how crucial is it when you are experiencing pain through these workspaces to not push through it and use the pain-free motion?
I love you brought that up. This is something that you don't want to push through the pain because it's going to lead to breakdown of structures or it's going to lead to inflammation of the inner joints, which can lead to other problems as well. So working out the pain-free range of motion and not moving to areas of pain, over time, the capsule will restabilize. It'll send resources to where when you go through that, let's say there's pain right here and you diminish and go around it, that area will shrink to where you're not going to have as much pain. 95 times out of 100 for most people. Oftentimes if there's an autoimmune condition or if there's other internal malfunctions throughout the body, that will limit that progression. But the body will send resources to build up that area quite well. So,
Perfect.
Yeah, good
Awesome.
point.
Awesome.
Good point.
All right, guys, that was episode 8. Thank you guys so much for watching. Please, again, like, subscribe, and just, again, we, from the bottom of our hearts, thank you guys so much for continuing to watch. Share this with everyone that you feel is going to be of benefit. And again, we'll see you on the next one, Doc. Woo! Here we go.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.